So today I'm going to talk about the revisiting forecasting for emergency department staffing. So my name is Sishuan Wang, very difficult to pronounce, but I'd like to point out that this is not the case. Yes. Okay, I think there is some kind of delay here. Yeah. Anyway, so I don't say that for the third time. My name Sishuan is very similar to Sichuan, if you know the Chinese food. So what's the research topic here? Anyway, so
are you spicy?
Yes, too spicy here, and the computer cannot handle me, so it got frozen. So what are we doing here? Yeah, I think so. Yeah, I think that's. So what do we do in this research? First of all, we develop a model to generate a categorical forecast for staff to patient ratio requirements. So the key point here is that I'm not doing point forecasting, okay? I'm doing categorical forecasting, which means I forecast for categories. Okay, you will see how I define those categories. The second thing is that, of course, we have our model. We want to compare the forecasting accuracy with a few benchmarks. So we will compare it with naive model, exponential smoothing, ARIMA model, T-best, and the random forest. So you have your forecast. It looks very good. What are you going to do with it? Okay. So for the utility of our forecast, we will provide concrete practical recommendations for NHS staffing in the emergency department based on loose window model. So let us check the details. This is the outline. I will introduce a little bit background for emergency department. I will introduce my raw data, how we handle the data, clean the data, and format the data. Then I will introduce our proposed forecasting model, how we evaluate forecasting performance. Lastly, how we make use of the forecasting based on the loose window model. So this is the workflow in emergency department. As you can see, like any planning, you need to have your demand forecasting. So if I can show the laser point, and this demand forecasting is usually based on your historical data. Then you translate your forecast into number of required staff. You check you have enough capacity. You make schedule. Okay. So this is our original data. We have one hospital emergency department in Cardiff, and we have every patient's arrival time. So whenever there is a patient visit that emergency department, it will register one entry in my data set. Okay. And the period is from 2014 and 2019, before COVID. So that's the original data. We are going to do the first key steps. The first key step is I'm going to count the number of patients in 3 shifts of each day. So 3 shifts means morning shift 1 from midnight to 8. Then the second shift 8 to 4 p.m. The last shift is 4 p.m. to midnight again. Why I'm going to do this kind of number of patients? This is because your staff is allocated per shift. Okay, so this is the thing I caring about. How many patients are going to be in each of the shift? So if I just count all the patient arrivals, I got the number of patient visits in each shift in each day of my sample period, that 5 years. Those are the summary statistics. As you can see, the morning shift have relatively low number of patients, and the second shift and the third shift has relatively high number of patients, and you can see the other summary statistics. Then if you plot the time series of each shift, it looks like this. And if you plot the histogram of number of patients in each day of the week in 3 shifts, it looks like this. So as you can see, the day of the week obviously play an effect here. So I'm going to do the second important step. Okay, the first step is just count how many number of patients in each of the shift. The second key step is that I'm going to convert the number of patients into categories. Okay, remember that's the point of this paper. So we are not going to do point forecasting. We are going to make categories, and I'm going to make 6 categories here. I show you in front of your eye. Then I'm telling you why I'm doing this. So I go back to this slides. This is due to the staff to patient ratio. Okay, so because each nurse will at maximum take care of, let us say, 20 patients or 30 patients according to the emergency department requirement. Okay, so in that sense, let us say if your forecast is 51 and 52, it won't make any difference in terms of staffing. Yeah, because 51 and 52 in terms of forecasting, there is 1 in terms of absolute numbers, but in terms of staffing, it will be the exact same. So that's why we are going to make this 6 shift, and this 6 shift looks like this: from 0 to 50, then 50 to 100, and then adding the other 50s. So this is my category 1, 2, 3, 4, 5, 6, and in each of the category will have specific allocation number of nurses and doctors. So you will make the argument, okay, is it very important that if I jump from here to here, just across the boundary, I'm going to tell you, yes, that is important. Because if you don't allocate enough nurses and you are exactly here, your nurse will overwork, and that is not good for the emergency department. So I'm telling you that in each of the bucket here, okay, the allocation of the staffing will be the same. That's why we directly focus the category. We are not focusing the points. Okay, so this is the second important. So what is the x-axis here? It's just the number of patients admitted in 1 shift. Okay. Yeah. Okay, so obviously, this is a category. We need to specify the special models. So the model I'm going to use is called the ordinal regressions. So as you can see on the left-hand side, so this is the odds, log of the odds that one specific category happens. And on the right-hand side, it looks exactly like the OLS and like the other regression, linear regression models. So basically speaking, you need to figure out, come up with those predictor variables. And what predictor variables do I propose? So I'm going to predict 4 groups of variables. The first one is deterministic variables. It includes which shift, time trend, months of the year, day of week. The second category is holidays. So those holidays include public holidays, school holidays, celebration days, and because it is in Welsh, rugby is a big thing in Welsh. So we include the rugby matches. As you know, if there are rugby matches, there will be like a lot of drunkards, which cause problems, which will increase the number of patients in the hospital. And another thing is that I include leg and the knees. What does it mean? Okay, so if tomorrow, this is the need, is a bank holiday. Some people go out and celebrate, they get drunk, they go to hospital. Okay, The second thing is that if yesterday was a holiday, yeah, some people had drunk, they have hangovers, they feel, okay, I need to go to the hospital. So the need and the lack also important here. The next category is the lack of the dependent variable. So how many number of patients in the last shift plays an important role, and how many number of patients in the previous day, in the previous week. So in this way, we capture some kind of seasonalities. The last thing is that we are going to do interactions. We are going to have the shift multiply calendar variables. So I'm going to make the shift, which is this guy, multiplied by all the variables in the second category. Of course, if you count all those variables, it's going to be a large number of variables, and you need some type of variable selections, and we are going to use lasso. And I just assume that everyone here are familiar with lasso. Just one sentence summary on this method is that you have a penalization in your optimization problem, so that your estimated coefficient push to zero if they are not important. In this way, you automatically select the important variables. Okay, so just a little bit of summary on my model. So left-hand side is the log of the odds of the category. On the right-hand side, those are my selected variables. And some of them are important, some of them are not important. Lasso will help me to select them. Okay, how many time do I have? 5 minutes, fantastic. Okay, so I'm going to compare my forecasting models with 5 benchmarks here. And the forecasting design is that I have 70% of my sample as training sample and the rest as testing sample. Because Lasso has a tuning parameter, which is lambda, I'm going to use 5-fold cross validation to optimize this lambda. And just to remind you, what does my probabilistic output looks like? Okay, so if you look at the output in RStudio, you will see that in each of the category, it is associated with a probability. So for example, in the first row, the highest probability is in category 3, which has 72.1%. Okay, so this is my output. They are all probabilities, and they are not point forecasting. You need special evaluation method for your forecasting. So this is very standard in probabilistic forecasting. I'm going to use Breyer score and the ranked probability score, RPS. So those are the results. As you can see, I have different forecasting horizon here. So those are in terms of number of shifts. So H is equal to 3, means 1 day ahead. So 21 shift means 1 week ahead, etc. So Lasso obviously has the lowest BS score and the RPS, which indicates, okay, this is has a fantastic performance, forecasting performance comparing to the benchmarks. Okay, obviously, in the beginning, I show you, I just cut categories in IV 50, but the people can say, why 50? Why not 40? Why not 30? Why not 20? Okay, I show the result here as well. So there is no big difference. Lasso still perform the best. So the last thing I would like to say is that, okay, you have your forecasting result, so what? Yeah, this is the question people always ask me in terms of forecasting paper. You have a fantastic forecasting method, so what? So I'm going to tell you, so what? So you can use those probability forecasting output for concrete recommendations for staffing in the emergency department. And this is based on the news window model, which is a classical operational management model. So you basically have a few variables, 4 key variables. You have your decision, the staffing, and then you have the uncertainty demand, you have the underreach cost, you have the overreach cost. And you don't want to overreach, you don't want to underreach. And So if you go to this model, actually the decision is pretty straightforward. You have your cumulative probability in terms of category. You just make the cumulative sum from category 1 all the way to one of the category, and then you have the what we call the fractal here, which is the cost of underage divided by the summation of cost of underage and overage. And then this is the result. I'm just trying a number of underage costs and overage costs, and that's the fractal. And those are the results. If your forecasting performance is by lasso, and you make your staffing in terms of lasso and the other two methods. Okay, and then those are the costs, eventual costs I calculated. As you can see, no matter what the cost you calibrate here, lasso always gives you the lowest total cost. And in this way, we show that, okay, actually, if your planning is based on our lasso probability forecasting, you can be more cost effective in terms of your staffing in the emergency department. So I guess I run out of time. There is no point to do the summary. I believe you will remember my slides very well. So thank you very much. And I just want to show you one last slide, which is a shameless promotion on the grant. So Beckman and I had a forecasting for social good research grant, $5,000 US. So this is for lower income countries. Okay, and the principal investigator must be the lower income country, but co-investigators can be you guys if you are not from lower income countries. And those are the deadline. So if you are interested, you can scan the QR code. I also have some flyer here for you to take away. So thank you very much. Thank you very much.
So yeah, please.
The question is around how did you calculate overage and underage costs, and then did you do any sensitivity on the outcomes of the changes in costs?
Okay, so we don't have the specific number for the cost, and these numbers I show you here. For example, the first row is underage is 0.56 and the overage is 5. That is conceptual numbers. Okay, that's just for academic papers. Obviously, if we have the real numbers from the hospital, those can be exactly calculated. Yeah, this number here is just conceptual numbers, and the sensitivity is that I try to change the underage cost, and then you will have different fractals, and this fractal is a key important decision criteria in terms of staffing. And then if you try all of them, lasso is consistently better.
Thank you. One final question, maybe. All right.
Except for the lasso model, have you ever tried any other focusing model, for example, artificial networks?
Yep. So we try the naive model ETS remark best one.
For in terms of the lasso, I think maybe some other machine learning model or different model artificial networks could perform more precisely result. Maybe in this paper, that also is perform well, but maybe in the future,
Yeah. So there are many choices of forecasting methods. Or we obviously can try many of them. Random forest is one widely used machine learning method is included here. Obviously, we can include other methods as well. Yeah.
All right, thank you very much. Do we have a second presentation here now? Yes.
Okay.
So let me take this off so you can put your presentation.
I suppose there is an internet connection, right?
Should be. Do you have your USB stick?
My slides are online, so I can.
Okay, try.
I just. Nice. Okay. Shall I share my screen? It is already shared, right?
You need to close my slides
So this
first.
one.
Yeah, close over. Yeah. And then Control 11.
Okay.
Okay, just.
I have 11.
All right.
So we are gonna see on the TV. So you're gonna see.
All right. Okay, lovely.
So we can try to take this.
All right.
Okay. I cannot see the screen over there, so.
Yeah, it's weird.
Any way to hide this? This one? Okay.
All right, lovely.
Thank you.
Okay. Hi everybody. My name is Bahman, and I'm a reader in business analytics at Cardiff Business School. I got this shirt from India a month ago. I was there, and the temperature was 48 degrees. And I thought it's a good opportunity to use it actually here in the UK as well. So that's why I chose. So today I'm going to talk about a paper that we have written with Jetro that is here and even in the back about probabilistic forecasting of hourly emergency department arrivals. And the slides are available in my website. So if you are interested, you can see them there. Okay, how should I move? The keyword is still doesn't work.
No, that doesn't work, unfortunately. Can you try this? Okay.
Which one? The Inter?
No, this one.
Oh,
Yeah, for.
all right, lovely. Okay, so this is the outline of my presentation, and I was the co-author of the other presentation as well. So I know that Shishwan has already talked about the emergency department and how forecasting might be used and important there. So I very briefly talk about that. And then I present the data because it's important to see how data inform the modeling process and what is the forecasting setup. And then I briefly talk about the forecasting model development and how we evaluate it. And finally, conclusion and some future works. So these are some news actually from UK, but I assume doesn't matter where you look at the emergency department, you see this sort of news. So that highlights how important the emergency department is and how important is the management of an emergency department. And again, here we talk about forecasting. So I'm not claiming that if you even forecast the demand accurately, all the problems suddenly disappear from emergency departments, because NHS and healthcare and in particular unplanned care and emergency is quite a complex system, and there are so many factors that affect each other. But nevertheless, having an accurate forecast will definitely help in better managing the emergency department. So how forecasting is used in emergency departments, well, it could be used in different ways. One of the most important ways that forecast could be helpful is with the staffing problems. And a simple question is how many doctors and nurses we need and when we need them. And this helps if we can provide an accurate forecast. Well, we can have, actually we can help with, with help patients, because hopefully the emergency department would be less congestions there and they benefit from it, but staff also can benefit from it, you know, because they will have less pressure and working under pressure there. But in general, it can help to reduce the cost in the system as well, including staffing costs, because if they are understaffing, that what they have to do is they have to go and call for external agencies to bring, and that costs more money as well. So this is basically where forecasting meets staffing. So you have some historical demand as we have here, and also some other information that you use. You generate a forecast. That's what we do in this paper. But then you have to translate this forecast into staffing, but that's actually beyond this presentation. So I'm just talking about how we do the first part, but then the rest of it is very important as well, but it needs doing more like simulation and things like that. So, oops, actually there was a table here, for some reason it doesn't show it. So I did some literature review just to find out in terms of because there is a huge literature in emergency department in general, but I was focusing only on hourly forecasting. And I found a couple of papers, I think around 24 papers that focus on hourly forecasting in emergency departments. And then we were interested in finding like what are the limitations. And one of the limitations that we found across most of these papers were, most of them, they look at just the point estimation, and they don't go beyond that. And the point estimation in the forecasting is just the expected value, right? So it's like an average. And the problem is the average could be misleading. So it means it is likely that it's hiding something, because at some point you will see a surprise if you're just relying on that. I don't know if you're TikToker or not, but I'm sure at some point you may saw this. So it is like, actually, that's exactly what I'm talking about, right? You're trying to do something, you evaluate and everything, okay, it's more or less like that. And you estimate the average is fine. And suddenly there is a surprise, right? And this is exactly the problem with the point estimation. Because if you're relying on this to make decisions, and you feel actually the point estimation gives you an illusion of certainty. While we all know that, and there are many talks in this conference, that we know that we are living in an uncertain world, but we are a lot of uncertainties. But that's the issue with the point forecast. And that's why we are interested in this, and we try to do something more. But there are also other limitations, in particular in the area of healthcare. And these limitations, well, at least for the hourly forecasting, it includes, so there are a few studies that looks at the models that include multiple seasonality. That's another thing. The studies are not reproducible. They are limited in terms of length of historical data. And then most importantly, there is a lack of rigorous experiment. Like some papers, they don't even report forecast accuracy. There is no benchmark to compare gains. And then they don't use time series cross-validation and things like that. So our objective is, and based on the limitation in the literature and the data as well, to develop a probabilistic forecasting model that takes into account these important factors. And why these factors? Because then we have a data, and the data inform what's about that. And that's what I'm talking about now. Do you see the full screen? Because for me, it's a bit strange in my screen here. Yeah. Yeah. For example, I don't see my titles here. Okay, but anyway, there is a title, but I don't see it in my, here as well. Anyway, so this is basically we're plotting the whole data here, which includes a couple of years. So in the x-axis you see the arrivals, in y-axis you see the day of week, the hour of the day, and then the different colors show the day of week. And then we see the distribution, so how actually changes within the day, right? So You see this shape, and it's a typical of emergency department. No matter where in the world you look at that, it looks like this most of the time. And then also you notice during, for instance, from 8 a.m. to like say 4 p.m., Mondays are quite different from the rest of the day, and distribution is different as well. So the distribution for them from midnight to morning is more or less the same. But again, the impact of Sunday and Saturday, maybe they are a bit more comparing to the rest. But then during the day is very different. And again, at the end of like from 8 a.m., again, it becomes a bit more similar. We can also see this from another plot. This is called the seasonal plot. I like this plot. Some people, they don't like it. But so here we have one line for one day. And then basically this helps us to see whether there is a seasonality. And then here we see that different days, different 24 hours follow the same pattern. And this is what we call a seasonality. You know, a similar pattern within a fixed period of time. And the period of time is 1 day, 24 hours here. But there is a variation as well. Okay, the lines follow the same pattern, but we have the variation within each hour as well. We can also look at something similar to this in day of week. So again, here we see so each line here is 1 day. So we plotted all the data here. And again, we see that they follow the same pattern, but again, there is variation. So in the previous one, we had a daily seasonality. Here we have a weekly seasonality. And this plot shows also the week of year seasonality. This one shows how important are certain days. You know, for example, you see some important days with very low or very high arrivals. These are like special days, holidays, Christmas, New Year's Day, and this sort of thing. So again, it's important to consider them. And there is a slight long-term trend as well in the data that we need to account for. So these are the characteristics that we see in the data. Well, there is also like autocorrelation and impact of autoregressive lags and things like that, like something similar to Shishwan discussed about lagged and lead indicators or predictors that are present here as well. So here we forecast for 48 hours. We do time series cross-validation with re-estimation, and then we use 1 year of data for evaluating. To evaluate the point accuracy, we use root mean square error. And to evaluate the probabilistic forecast, we use the quantile bias and pinball score. And the pinball score, we look at different quantiles from 5% to 95%. All right, now, okay, in terms of the methods, so we look at the different methods. These are the benchmarks. And then in terms of the model that we develop, so Ivan developed a model, and he's written actually the whole book about this. The book is available for free, so you can also look at the book. So this is the first model, ADAM, which is multiple seasonality IETX. So this is based on exponential smoothing model, but then it takes into account also more predictors that we have discussed here. So again, I can go into details of all these predictors, but you can find more information about the model itself in the book as well. And then following that, JETRO focusing on another family of models, generalized additive models. So these are typical models that are good to capture nonlinearity and this sort of thing. Well, again, this is quite complicated, so I leave it to JETRO. If there was any question related to this model, you can also, I think, ask JETRO in terms of what is there. I can also explain some of the important things here, but I think what we have to keep in mind here, this sort of model like GAMS, and in particular the one we have looked at here, is capable of capturing nonlinearity, but one particular thing that is important here is using different distributions. And that makes it powerful because we can use the different distribution and see whether it is helpful changing, I don't know, Poisson to T distribution, or I don't know, truncated normal distribution, for instance, in our case. So again, more details about the model. And again, this is a source if you are interested in the GAMS in general. So some findings. So as you can see, we have a list of like many models because some of these models are the variations of the models that Jetro developed. I don't know, you change the distribution or you include some of more predictors in one model and not others. And then we evaluated this based on quantile bias, pinball, and RMSE, but we also captured the time. That should be just one column, running time. So this is basically the result based on the pinball. We didn't put all the methods here. We just put the most accurate ones. So I think what we can see here that some models are definitely much better than others. For instance, a model like TBAS is not particularly good here comparing to, for example, the model that which is Adam ETSX based on exponential smoothing, including regression and also the predictors, and also NOTR2, which is again another model based on the GAM that was developed by Jetro. And TBATS, for instance, is a model that can take into account multiple seasonality, but in terms of the pinball was really bad, as you can see. In terms of the quantile bias, again, you see that TBATS is pretty bad because here we are interested in the models that are very close to this red, the dashed line. But again, two models performed pretty well here, the Adam IETX and NOTR2, which again is a model based on GAM with a truncated normal distribution. And then based on root mean square error, well, again, these models again perform well comparing to others, but surprisingly, we had also a simple exponential smoothing that was quite well if comparing to the others for the point estimation. And then, again, this plot shows the accuracy versus running time. And then again, this is a good guideline to see whether you are interested in a model maybe to be more accurate, but is there a cost related to that, whether it is it needs a lot of running time to get the result, or maybe it is quick. So again, this could be very helpful. So in terms of conclusions, so two approaches developed by the team. They are calibrated forecasts and they are accurate in terms of the accuracy measures we considered. The point prediction produced by Adam ESTX had a lower root mean square error than the other one, which is based on GAM. But the model produced based on GAM and truncated normal distribution produced forecast with a lower pinball score. So that means if you are interested really in the probabilistic forecast only, you should use that one. But if the point forecast only matters, maybe Adam ISTX is a good choice as well. Another important thing that we find out is the choice of distribution assumed for the probabilistic forecast and the choice of model features, like what you include as predictor, is really important. And then another thing is the best performing model handled the non-negative and skewed nature. And why this is important, because we had some zero values in our time series. And if you use like classical models, you get normally negative values. So you have to do some transformation and pre and post processing. So here we didn't need to do that. Well, I think I discussed some of this. Maybe one important thing is out of the box models like Profit, like TBATS that require minimum tuning parameters. We didn't perform really well as comparing to the models we consider here. And I think there are also some important kind of future work that we can do. And most importantly, linking probabilistic forecasts to decision making is really important, because we talk about this a lot, but in terms of practicality and how beneficial this could be, I don't think there is much. I know in the room there are people also work on this kind of problem, but there is not much research there. And in terms of implementation and using it in practice, probably there isn't any work really there. So I think these are two important problems to look at in the future. All right.
Thank you very much. We have two related questions. How relevant is hourly forecast for the department?
How often?
How relevant? How relevant?
Oh, okay. So how relevant? Well, if you ask me about the real practice, maybe not really. So in terms of how now people do things, they don't use hourly forecasting, but hourly forecasting could be used, to even help you with long-term staffing. Why? Because how the scheduling algorithms work. A scheduling algorithm works actually sometimes even based on 15 minutes, depending on the scheduling algorithm. Sometimes you need a forecast for 15 minutes. For instance, you have breaks because you want to schedule staffs to make sure, during the break, some people, they have breaks, some others, they don't have. So you need that interval of 15 minutes, for instance. And you can run that, here we look at the 48 hours, but you can run this for longer term, but still with that time granularity. And that fit into the scheduling algorithm. And then you can not only have the scheduling, like details of it, but that help you as well to get your staffing, let's say for next 2-3 months, something like that. But also it could be used, to adjust things in advance. Again, depending on how much horizon how long the horizon is, you can use the hourly forecast as well to make adjustment. This sort of thing happens as a judgmental thing normally. So people based on experience, they change things. Again, my understanding of using forecasting in this kind of context is a systematic thing, is automatically forecasting is fitting into scheduling, and the schedule is created. This is just the imagination that we have in mind. The reality is completely different. It's just they're doing it manually based on experience and things like that. But yeah, we hope that if we do this kind of studies, we can also motivate people that there is a way to do it. And actually, one of my PhD students is working on this problem with Welsh Ambulance as well. So how we can integrate the forecast into the staffing and ambulance scheduling as well.
One final question, please.
How did you use temperature in the model? Was it actual temperature or forecast or fluid temperature?
Jetro?
I can prepare the presentation for the next one.
For example, ice or precipitation, like more
Well, I think temperature. There are lots of people in healthcare, particularly NHS, they talk about using temperature, but it seems that there is no benefit of really using it. And there might be different reasons. One reason is because it's a variable that you need to estimate, and normally the estimation, as you go further, long term, may not be really helpful. And another reason is maybe actually the data that you have, like seasonality and all the temporal elements, or they capture important features related to that. And for instance, I don't know if not in the NHS, but if the temperature is high, then more people go to that in the summer, and then maybe that summer somehow already captured in the other features. And I'm not really helpful.
I think the point is the models today and forecasting is also aggressive.
What about the lunar cycle?
Sorry?
Lunar cycle. And it's actually something that I think is perhaps predicted, because if you talk to anyone who works in emergency, they say there's an update.
Okay, going back and forth. Okay, that's true. I can do.
All right, thank you very much, Mohan. So we have the last but not least, Selma from just to remind you once again, Selma is a student, so maybe you can like to wait for the award. Thanks.
Okay, so good afternoon, everyone. I'm Salma Al-Bareki from Khalifa University, the United Arab Emirates. And today I'll be presenting the preliminary results of the research using Bayesian network model to explore the influencing factors of the incident reporting in healthcare. And I'm happy to consider any feedbacks and questions at the end of the presentation. So this would be the outline of today's presentation. First, I'll give a short introduction about the topic, And next is the problem that this research aims to resolve. And after that is the goals and objectives. Next is the methodology, data set, results and analysis, and finally the conclusion. So how safe are healthcare systems? As there are growing awareness on the number of medical errors happening around the world. So just to give an example of the numbers in the US, there's a recent study that happened in the Johns Hopkins. It shows that medical error is the third leading cause coming after heart disease and cancer. They also published that around 250,000 patients were affected and died because of the medical errors. And moving on to the numbers in the UK, we can see that 1 in 10 patients admitted to hospitals are affected by medical care, where almost half of them were preventable. And around 200 million medication errors occurred in the National Health Service here in the UK each year, which has the avoidable consequence that costs the NHS of £98 million and 1,700 lives each year. So there are various ways to improve the patient safety, and one of the significant approaches is to learn from incidents. So incident reporting refers to a voluntary patient safety initiative whereby nurses and physicians complete a report about the medical mistake that happened, both the near misses and the unsafe conditions. And it's important to understand how many incidents occurs in an organization, how many of them are reported, and how many of the reported ones are being investigated. So the steps shown here in the figure are designed to ensure that the reported incidents are properly supported so that the departments can encounter actual improvements in the safety. So as we can see here, first, the organization should be able to detect the incident, both the ones that had caused adverse events and the ones that had the potential to cause one, such as the near misses. And after that, a report should be completed so that the investigation stage can be started. An investigation stage, it studies the facts surrounding the incidents in order to discover the root cause of this incident. And after that, recommendations should be happening and learning from this incident and sharing them with the staff. Okay. So in complex healthcare systems, incident reporting is not just impacted by one factor, but it's impacted by multiple factors, such as teamwork, leadership, and management, and much more. And as mentioned previously, that the incident reporting is one of the most important factors in the patient safety. And earlier studies had showed the importance of management and leadership, but still there is no study showing the interactives in systems and how each factor can influence the other. So the aim of this study is to explore the organizational factors that influences the incident reporting in healthcare by using a Bayesian belief network model. And the list of objectives are as follows: is first to analyze the different organizational factors impacting the incident reporting, then to identify the relationship between these factors using the Bayesian belief network model, and finally to visualize the relationship to show the dependencies among the interconnected variables. So as mentioned previously, that I will be using the Bayesian belief network model to find the factors influencing the incident reporting. So Bayesian belief network is a probabilistic graphical model that represents a set of variables and their probabilistic dependencies. So as you can see here, that the Bayesian belief network model, it consists of variables, which are the nodes, and the relationship between them, which are the arcs. And the strength of dependencies among the interconnected variables are captured in a form of probability distribution. And the probability distribution of each factor only depends on its parent. So as we can see, D is the parent of C, C and E are the parents of B, and so on. And here's the equation of the probability distribution with n number of nodes, where the PAXI is the set of probability distributions corresponding to its parent XI. So Bayesian belief network model are now being recognized as a powerful tool for risk analysis and decision support in real world. Although Bayesian belief network has been successfully explored in many applications, it still doesn't have much impact on the patient safety context, especially in the incident reporting. So here are some of the Bayesian belief network features. As we can see, it's a graphical presentation identifying the interrelationships between the variables. It also identifies the causal relationship between them. And one another thing that it can do, it can be analyzed with what-if scenarios to predict different outcomes. Another thing about the Bayesian belief network model is that there are different machine learning algorithms that it works with. So in particularly, I chose to work with the tree augmented naive Bayes algorithm for many reasons. And one of the main reasons is that we assume that we have one class variable that has a direct edge to all featured variables. And for the TAN model, it also allows for one-level interaction between the random variables. So because the interaction between the variables are limited to one, the complexity of the model is being reduced. So the TAN model maintains the robustness of the naive models, as well as increasing its accuracy. So the procedure that I followed in this study is first, I identified the organizational factors that influences the incident reporting from the NHS staff survey data. And after that, this data was checked for missing values, then discretized into different states using the k-mean clustering method in Python. And next, the Bayesian belief network models were created using different discretization schemes in Gini modeler. After that, we chose the best Bayesian belief network model based on its prediction accuracy. And next, I used different features in Gini modeler, such as diagnostic analysis and scenario analysis, to identify which is the influencing factor of the incident reporting. So to understand what are the drivers of the incident reporting, I used the survey data from the UK hospitals. So the UK National Health Service provides this open data online for staffs, where it enables the organizations to survey their staff in a regular and systematic manner. There are nine reporting themes in the data that might be relevant to the patient safety. So these factors will all be tested on their interdependencies between them and the incident reporting practice. And as you can see, the last factor on the bottom is our target variable, which is the incident reporting investigation practice. It is one of the questions from the data which says that when errors, near misses, and incidents occur, the organization takes action so that they make sure that that does not happen again. So next, we needed to discretize the data, as most of the Bayesian belief network algorithms and the tool that I'll be using to model the data only works with discrete data. So the k-mean clustering method was used to discretize the continuous variables before modeling them. And this method was conducted in Python using the scikit-learn library. So the k-mean is a popular method in data clustering. It is a partitional-based clustering that uses the centroid model, sorry. And before using the k-mean, I had to find what is the numbers of the centroid. So there are two methods to find them. I used the Selhout method in order to find what is the value of k. So the Selhout method is a fully automated method carried out through the analysis. It finds the Selhout coefficient, which is the measure of how similar a data point is within a cluster compared to other clusters. And the output of this analysis gives us a graph, as you can see, where the y-axis is the Selhout coefficient and the x-axis is the value of k. So for example, for this variable, it shows that the value of k is 3, which is the highest Selhout coefficient. So the result of using this method is shown here in this table. As we can see that some of the variables had resulted with 2 clusters, while the others had 3. So in this study, we worked with 2 different discretization schemes to convert the continuous variables into categorical variables before modeling them in Gini. So Gini Modeler is a graphical user interface that allows the interaction for models and learning the model. So what we did is we built 2 different models, one with 2 states and one with 3-state data. And after that, these models were verified using the k-crossfold validation approach, also implemented in Gini Modeler. And the prediction accuracies of both discretization schemes are shown here in this table. So as we can see that the 2-state had a higher prediction accuracy with 78.7%. And the following procedures was implemented in 2-state discretization scheme using the tree augmented naive Bayes algorithm. And after that, the confusion matrix, which illustrates the relationship between TAN's algorithm, actual and predicted states, were also found. So the numbers in bold detect the predictions, the correctly predicted values of the class node, which is the incident reporting. So in the validation stage, out of 371 records tested, 292 were correctly identified, giving us the accuracy, which is the 78.7%. So this is the output of the model that we found in the Gini modeler using the TAN algorithm. As we can see, there are 9 different factors affecting the incident reporting. And we can see that all variables are dependent variables, and it also has one direct edge between it and the class variable and one extra variable, except for, as we can see, managers. Managers is the only independent variable. So this node is called the root node. We can also see that there are arcs going from the class variable to all other variables, assuming that they influence the class variable. So it's the opposite way. And moving on, the probability distribution of the organizational factors were also found here, as we can see in bar charts. We can see that for the class variable, 55% of the cases were for state 1, which is the high state, and 45% of the cases were for state 0, which is the lower state. And Gini modeler allows you to conduct different scenarios to see how the factors can affect each other. And for the next slide, we're going to examine the high state of the incident reporting. We're going to have it at maximum, which is 100%, to see how the other factors will be affected. So this analysis is called the backward propagation. It is one of the scenarios which is having the class variable at maximum. And we also did the impact assessment here, which summarizes how the probability of each variable and how much is it affected in percent. So as we can see here in the figure on the right, it shows that staff morale, staff engagement, morale, immediate managers, health and well-being are the top 4 factors that had a higher increase in percent when having the class variable at maximum. And another analysis that was also done is the diagnostic analysis, which is a feature that users can gain an understanding of the variables that can influence the incident reporting practice. So therefore, in this method, it's about looking into the association of different factors and the class variable. And the objective of the diagnostic analysis is to determine the cause of the problem so that classification-based decisions can be made. As we can see here, that this figure shows the observation ranked from most to least informative. And we found out that morale was the most factor that influences the incident reporting. And after that comes the staff engagement. So risk managers and policymakers should promote morale and staff engagement to gain major benefits from their reporting practice. And the last scenario that we've done is the forward propagation. So after knowing which are the 2 influencing factors of the incident reporting, we had them both in maximum state. As you can see, state 1 had the maximum state, which is 100%, to see how much the class variable, which is the incident reporting, would increase. So previously we had the incident reporting at 55%, and now we have it increased up to 92%. And in conclusion, after adopting a data-driven Bayesian belief network, we investigated that morale and staff engagement were the 2 most influencing factors after conducting the scenario analysis and the diagnostic analysis. So it's discovered that employees with positive morale shared effective practices, inspired and facilitated quality improvements. And staff engagement increased the staff commitment towards attaining organizational goals and objectives, including the patient safety. So healthcare organizations should support a better staff experience to prevent incidents that may harm patients and staff. So as a result, morale and staff engagement may require additional attention for new safety improvements to be realized. And this study had some limitations. As we can see that the data was limited to the UK hospitals, so the generalizability of the data may be limited for other countries. And one another limitation is that we needed to discretize the data before modeling it, so this could reduce the accuracy of the model. And because we're using the staff survey data, we could have missing values, and the use of hospital level data could be also a big limit. And for future research, we may benefit from the consideration of other factors and features, such as environment, culture, and other factors. And analyzing the data from a specific hospital would be more useful instead of just getting average values of multiple hospitals. And we can also compare other countries' results and see how other countries' factors could also be different. And finally, alternative discretization methods or machine learning algorithms could also be integrated further to compare the prediction abilities of the models. So thank you all for listening, and I would like to thank my advisor, Dr. Andre, for his support.
Thank you very much. So it's a very nice presentation.
Thank you.
So I have several questions. So I noticed that you mentioned the PNN algorithm, right? So that's what your predictor is. And when you say you use, I mean that several classifications based on the data that's what is the features like the predictor. What is the predictor class?
So for the TN algorithm, I had to choose the class variable, which is the incident reporting, and I have to input all the other factors, which are the 9 factors that I already introduced. And then it will come up with the network, which is having the class variable and all other factors surrounding it to influence the class variable.
Thank you. Any other questions? Yes.
I'm thinking, I was just wondering, without going into the details of the philosophy about more, what is more. So I think so it's an important conclusion, but then if you want practically to do it, what do you think you need to do to actually use more of it?
Maybe we can train the staff, motivate them more to come to work. So after training them, they could be more motivated to report the incidents that they see. And here are the questions that were in the survey that's linked to the moral factor. If you can see here, there is around 10 questions.
And how big was the sample?
I used 3 years, 3 years survey data, which is around 371 organizations.
How many incidents were there?
They didn't mention the number of incidents in the data. It was not mentioned.
Thank you. Any final questions? Otherwise, we can conclude this session. All right. Thank you very much, everyone.